Hi, welcome to this presentation on immune-related adverse events, the nursing perspective. My name is Alexis Parent. I'm a nurse practitioner in medical oncology.
I'm Anna. Right now, I'm an advanced practice nurse at the MUHC in the Cancer Care Mission.
First of all, we want to acknowledge that the MUHC is on a land which has long served as a site of meeting and exchange amongst indigenous peoples. We acknowledge and thank the diverse indigenous peoples whose presence marks this territory on which peoples of the world now gather.
Thank you. So we don't have any conflicts of interest, but we may be a little bit biased. We're really happy there's a nursing stream this year, so thanks for being here this afternoon. First of all, just to go through our objectives for the presentation, first we're going to tell you how we chose our topics for the day. By the end of this presentation, you guys should be able to describe and particularly teach the mechanisms of action of cancer, immunotherapy, and immune-related adverse events. You will gain some familiarity with various types of reactions. You'll understand the guiding principles of immune-related adverse events, for their management, and you'll also acquire some practical resources that can help with your nursing practice. So how did we choose our topics for today? And this presentation, by the way, came about thanks to feedback from last year's inaugural presentation, identifying a need for practical information that could help inform nursing practice. So that's what we were aiming for. We sent out an electronic survey using forms to both inpatient and outpatient nurses at various hospitals on the island of Montreal. And so these are the results of our survey. We only had 4 questions. We wanted to keep it simple. So first of all, what our results showed was that 70% of our respondents actually felt they had some knowledge about the most common immune-related adverse events and their treatment, whereas 15% of them did not. The rest of them were neutral. Based on their knowledge, their pre-existing knowledge, only 55% of nurses felt comfortable caring for, assessing, and educating patients experiencing immune-related adverse effects, and 25% acknowledged not feeling comfortable with that part of care. We also asked nurses to rate in order of preference and interest different subtopics to talk about today. So in order of preference, people wanted to hear about acute clinical manifestations, long-term implications, treatments, pathophysiology, and patients' lived experiences. And finally, we used an open-ended question to help to elicit some suggestions for topics that didn't fit into the questions that we asked previously. So before we delve into more of the content, I want to explain why patient education is really the #1 proactive way to manage immune-related adverse events. So since 2010, when ipilimumab was approved for use with metastatic melanoma, the number of indications approved for immune checkpoint inhibitors, so this is not even including cellular therapies, has increased massively. This was a list that was compiled last year. And so earlier on with Dr. Naidu's presentation, she mentioned that we're already over 60. So indications are being added all the time. Immunotherapies are often able to be given in an ambulatory setting, so this improves quality of care, quality of life for patients and their families because they get to stay home. It's also more efficient in terms of resource allocation. But on the flip side, because patients are at home more of the time, there's a limited number of opportunities for nurses and for physicians to perform full health and physical assessments. So in this context, we really need to maximize patients' competencies and engagement in self-care and self-monitoring. So just before we dive into more content again, I want to tell you a little bit about adult learning theory, because these are theories that really can be utilized by nurses to make their teaching more effective. Most modern adult learning theory is based on Malcolm Knowles' principles of adult education, which is also known as andragogy. This is kind of a trendy concept right now. So if you've been to other conferences recently, people are talking about andragogy. These theories have been applied to patient education strategies in the healthcare system with great success. So his principles basically boil down to these four, which may be familiar, but in a more of an informal way. So first of all, adults need to be involved in the planning and the process of their learning. So it's a good idea to ask patients their preferred learning style, offer them a variety of tools, written, visual, etc. And something that we may not do as much is to ask for our patients' feedback throughout the teaching session to make sure we're on the right track and we can reorient ourselves if it's not working for them. Second principle is that adults use their past experiences to help them learn. So, for example, you can compare the treatment of diarrhea related to chemotherapy, which they may be more familiar with from prior treatments, to the treatment for diarrhea after receiving immunotherapy. So that helps them to relativiser, put into relation these different approaches and the new information they need to retain. Third principle is that adult teaching is especially effective when the learning content has immediate relevance to their lives. So when you're doing your teaching, if you can address how immunotherapy will impact their personal and their work lives, that'll help. You can always share comparable patient experiences anonymously, of course, and that also helps to make things more tangible. Adult learning is also more effective when it's about problem solving rather than just memorizing a whole bunch of information. So we all know the teach back method to validate that our patients have understood and retained our teaching, but it actually might be even more effective if we present a problem solving scenario, like telling them you received your immunotherapy a week ago and this morning you woke up with a diffuse rash all over your arms and your legs. What do you do? And so working through that with them will help them retain it a lot better. So if you're developing educational material that's written or audiovisual, it's a good idea to also use a validated assessment tool to make sure that your educational material is easily understandable by patients and easy to put into application as well. So a lot of these do exist. One of them that's particularly interesting is the patient education materials assessment tool, which is a validated measure that's available for free online. So this resource is there. I'm also happy to share the slides as well if you're interested. So now getting into the nitty-gritty of things. Before getting deep into your teaching about immunotherapy, it's a good idea to ask your patients what they already know about cancer development and basically explain to them that this will make it easier if they have an understanding, because then they can just add the new information that we're talking about without worrying about having to memorize a whole bunch of new things. They might already be feeling overwhelmed, so understanding is easier than memorizing always. So if I had a patient who really didn't have a very solid understanding of cancer and its development, I would explain it something like this. So this is to give you guys some ideas if ever you have a teaching session and you want to try a new approach. So I would tell patients most cells renew themselves by dividing. So every time a cell divides, the DNA from the parent cell is replicated in the offspring, just like when we have kids. So every time there's a replication, there's a chance that something could go wrong. And so after generations of mutations like this, normal cells can lose the ability to function how they should. And so they can also develop new characteristics that make it harder and harder for the immune system to identify them and to eliminate the dysfunctional cells. So at that point, that's when we start talking about cancer cells. Normally, immune cells have receptors on their surface, known as checkpoints, that are blocked just the right amount of time so that they don't go wild and attack the whole body's normal cells and normal tissues. A common metaphor for this when we're talking about immunotherapy is the brakes on a car, which some of the physicians this morning, I think, used as well. So when immune cells encounter a foreign cell, the brakes come off, they attack and eliminate the threat. Cancer cells are able to present little proteins on their surface called antigens that bind to these checkpoints, and they press down on the brakes. So now the cancer cells are safe because the immune system can no longer see them or attack them or eliminate them. And so this is the basis of how immunotherapy works. So immunotherapies are drugs that act on various aspects of the immune system and the immune response to cancer, sometimes enhancing it and sometimes reestablishing function that was lost, just like we mentioned. Um, and so basically, I'm not going to get into all the different types of immunotherapies like the T cell engagers and the CAR T, which we've already talked about today, but we're going to look more closely at monoclonal antibodies and immune checkpoint inhibitors, which are kind of a subfamily of the monoclonal antibodies. So they're synthetic antibodies that are infused into the patient's body. They float around in the extracellular spaces until they find their target receptors, and they trigger various cell death mechanisms, or they block those little checkpoints, making it so that the cancer cells can no longer bind to them to turn on the brakes. So now the brakes are permanently off on those cells, and the immune system is able to attack. So these anti-cancer effects do take longer than traditional chemotherapy. So it's also important to set expectations with our patients about the longer timeline needed to see the effects and to be able to evaluate treatment response as well. A lot of patients are anxious and they want to scan, they want to know if it's working, but there's a really good reason why it's not helpful to do that, because there's a possibility of seeing pseudo progression on scans. So that's a phenomenon that tends to happen between 4 and 6 weeks after treatment. And so it's when the tumor like swells, grows, looks bigger on scans, but it's actually because of the immune attack, the immune cells infiltrating it. And so that effect does fade, and then it's a good idea to do your scans to assess treatment response. So we can do a little bit of myth busting related to those questions that we got in our survey. Someone asked whether antihistamines affect the efficacy of immunotherapy. So it's an interesting question, and the answer is not necessarily. There are several retrospective studies that were done that actually identified a slight positive association between the use of antihistamines, H1 antagonists specifically, so like the Benadryl, hydroxyzine, and the newer generation ones as well, the cetirizine, etc., and overall survival of patients receiving immune checkpoint inhibitors. So there's a biologically plausible explanation. There's a chain reaction between circulating histamines having a negative impact on the function of CD8 T cells. So that possibly makes it harder for the T cells to attack the cancer cells. So if you're blocking those receptors, then perhaps it can allow the T cells to function better. This association was not noted with H2 antagonists. So those are like the famotidine, antacids, etc. The hypothesis is that this is maybe due to the alterations of the gut microbiome that happen with those medications. But I just want to acknowledge that these are retrospective studies, not prospective, not clinical trials. So we're really far from being able to use this information in treatment planning. But if your patients need to take an antihistamine because they hung out with a cat and they're allergic, you don't need to worry, and you can reassure your patients. So now that your patients have a really good, solid understanding of cancer development, immunotherapy mechanism of action, it's easier for them to understand how these adverse events can happen. So since we're often taking away the brakes on the system, since we're often inducing cell death mechanisms, immune-related adverse events can affect any body tissue. So the immune system becomes overactive, and we start to look like Homer who's lost his brakes. Basically, as it was mentioned earlier, a quick shortcut is to think of any condition that ends with an itis because it's inflammatory, but there are also other conditions, it's almost infinite, where the adverse events can take hold. Just a word on the distribution of immune-related adverse events. There was a large retrospective analysis published in 2020 by researchers at Vanderbilt University. So they looked at their own data from their hospital, and they also pulled from the World Health Organization's database of safety case reports and adverse drug reactions. So they were looking at demographic correlations between these characteristics of the patients and occurrence of immune-related adverse events. Some of the noteworthy findings were that young people had higher incidence of colitis and hepatitis, whereas older patients had higher incidence of dermatitis, arthritis, pneumonitis, and myocarditis. Younger patients also tended to have more severe adverse events in terms of the grading, but that may be because of the nature of the adverse events that they're experiencing. Uh, when patients were hospitalized, young and old, older patients had longer hospitalizations and higher mortality rates. So in terms of the management of immune-related adverse events, we like to follow Cano's five-pronged approach. The first cornerstone of Cano's approach is a baseline, a really high-quality baseline assessment. So why is this important? Obviously, having a good baseline allows you to differentiate between pre-existing medical conditions and side effects from the immunotherapy. And because grading adverse events is often reliant and relative to their baseline. So basically, if you can identify and grade the adverse events as fast as you can, patients can access treatment also as quickly as possible. The adverse events don't have as much time to escalate and reach a stage where they're obliged to discontinue their anti-neoplastic treatment. So just to give a quick example that illustrates that, let's say you have a patient who calls you and reports that he's having 6 diarrheas per day. If you did a really good baseline assessment, you might know that your patient already has 3 or 4 diarrheas a day because of his surgical history. And so he's only actually having 2 or 3 diarrheas extra per day. So I don't know if you guys can read it, but that would make him a grade 1. If you didn't have a good baseline, you might think that he's actually having 6 diarrheas more than a baseline of none, and you would grade him as a 2. The interventions for a grade 1 colitis are often to continue the immunotherapy, but to rule out infection and treat symptomatically with loperamide, with dietary changes, and that kind of thing. Um, Whereas with grade 2 colitis, you'll definitely be holding the immunotherapy. You'll be doing all of the other steps, but you'll also be administering systemic corticosteroids. You might be consulting GI, you might be sending them for a C-scope. So you can see that this really alters the patient's treatment, illness trajectory and treatment plan as well. And another myth busting related to the questions we were asked. We talked about this earlier as well with Dr. Ladouceur, so I know she went into more detail. Basically, it was a big concern at the beginning of the use of immune checkpoint inhibitors as to whether patients with pre-existing autoimmune disorders could receive immunotherapy. The answer is yes. There's been several systematic reviews. The first one was in 2016, and there's been more since then showing that it definitely doesn't cause a flare of their pre-existing autoimmune disorder. It can, but generally, if the patient has symptoms that are well controlled to begin with, it's tolerable and it's worthwhile to give the anti-neoplastic treatment rather than not. So basically, the approach is to, if possible, if the patient's receiving a non-selective immunosuppressive treatment, to try to rotate them to something more selective and more specific. When their symptoms are stable, then you can start the checkpoint inhibitor. So Cano's second cornerstone is patient and family education, which we touched upon earlier. A suggestion here would be to really actively engage your patient in their baseline assessment. You can print out a tool, a diagram, something like this. And if they're practical or visual learners, they could actually do the writing and write out their baseline as you go through it with them. So this is a tool that they could take home. They could post up somewhere obvious on the fridge. And when they're wondering if a symptom is new or if something is different, which is sometimes hard to do when you're stressed out, when a lot is going on, they can refer back to this and it can be helpful. And just by doing an activity like this with your patient, we're already hitting three of Noel's adult learning principles. So Cano's third cornerstone is anticipation and monitoring. So once you've done your teaching, you have a good baseline, all that's left to do is administer the treatment, hope for the best, and maintain open lines of communication. So it's a good idea to make sure your patient has easy access to reliable sources of information. There are many handouts that exist for patients. The one on the left is from Cano, the one on the right is from the NCCN. So they're one pagers. They're available for free in multiple languages. So if your patient, for example, has one of these and posts it next to their baseline, they have a really solid starting place to perform good self-monitoring. Our fourth cornerstone in this approach is early detection and diagnosis of the adverse events. So grading scales are very organ specific, system specific, and it's a lot of information as we saw earlier in the day. So really it's a good idea to refer back to your standardized tools, the published guidelines that exist to avoid making mistakes, to avoid overlooking anything. One of the requests we also got in our survey was for a tool like CoStars to help with symptom management or symptom assessment and triage and telephone triage particularly. So we just wanted to highlight that the most recent updates to the CoStars guide do include considerations for patients receiving immunotherapy. If your patient reports a new symptom, it's a really good idea to take that opportunity and do a full head to toe, a full review of systems. Because if there's something overactive in their immune system in one area, it's not at all impossible that other stuff could be going on elsewhere, and they may not even have noticed because they're so focused on that one symptom. You should also anticipate ruling out other etiologies for their symptoms as fast as you can because you won't be able to start immunosuppressive treatment until that's done. The document on the left is the ASCO guidelines. So these are available for free online and they're super comprehensive. So our fifth cornerstone is treatment and management. Basically, to summarize, these are the main principles that we would recommend to think about when you're approaching the management of immune-related adverse events. We highly recommend to refer to organ-specific guidelines that we mentioned earlier. These are internationally renowned and validated tools. We also recommend to refer to product-specific guidelines like product monographs and to talk lots with your oncology pharmacist colleagues because each different product has a slightly different risk profile. So we should also expect that we'll be considering alternate corticosteroid sparing immunosuppressive treatments. More and more in the literature, those are what's recommended. And so there's lots of new molecules being added all the time. So again, refer to the guidelines because they include them and they're different based on which system or which organ is affected. Something that was mentioned earlier, also important, is that if your patients are going to be immunosuppressed, then they should also be receiving antimicrobial prophylaxis. So remember to just make sure your physicians have prescribed those as well. And it's a good idea at this point to refresh teaching with your patient and their family on infection control measures they can put in place to avoid risk for the patient. And to also expect that the taper of corticosteroids is going to be slow. And during that period, there's a high risk of a reflare or recurrence. So your patients should be on the ball and continue to self-monitor for the symptoms. So in general, you can expect that low-grade adverse events are going to require topical or symptomatic treatments. And then persistent low grade or high grade adverse events are going to require systemic corticosteroids and or other immunosuppressants, and probably delaying or stopping treatment entirely. So just a note on late clinical implications of immune-related adverse events. Um, as was mentioned earlier, some immune-related adverse events can become permanent, particularly the endocrine ones. So, for example, adrenal insufficiency, diabetes, hypophysitis, hypothyroidism, hypogonadism are unlikely to normalize even after the treatment has ended, and so they might require hormone replacement therapy for the rest of the patient's life. Some acute immune-related adverse events can also become chronic, and so they'll require long-term immunosuppression with all the risks that that entails. So you'll see a little bit more about that later. The chronic adverse events or new chronic illnesses that have developed have their own risks and their own complications. So, not to mention that your patient might now need to learn how to manage a new chronic illness in addition to their cancer. So, in this context, long-term multidisciplinary and cross-specialist collaboration is really important to establish even after your patient has finished their immunotherapy. So now Alexis will take us through some practical applications of these principles.
Thank you, Anna. I need to do a statement first. Nurses are the new heroes. I don't know. Thank you. Thanks to you. So I don't know if you have seen this picture, this creation by Bensky before during the pandemic. So nurses are the new heroes. And what is our superpower? Come on. Doing blood tests? Chelsea, more than that. Come on. Assessment? Knowledge, savoir-être, savoir-faire. Knowledge is our strength, our superpower, and we need to use that strength, that power. So I don't know if you read those books, but when I was young, You Are the Hero books, you need to choose like which side of the story. So if you're not reading, you cannot take the right decision. So in the end, reading, assisting to the Cantux conference can be a good thing too. But like learning, it's the best way to develop your superpower. So just few words on the nurse practitioner scope of practice. That's our tools, the nurse practitioner, to use that power. So we can diagnose, we can determine treatment plan, we can prescribe tests, medication, and treatments. We can perform invasive procedures for diagnosis and treatments. So we can do a lot of things. And if you want to learn more about our scope of practice, you can always see that booklet produced by the Programme québécois de cancérologie. So you can read that, and it's very interesting what we could do now in 2026. So let's start with the first case. This patient's like very straightforward. So he's 65 years old male, ex-smoker, ex-alcoholic. He's not on drugs. His past medical history was moderately differentiated colorectal adenocarcinoma. He did receive chemotherapy and radiotherapy. He had diabetes, hypertrophy, prostate hypertrophy, NASH, thrombosis, and osteoporosis. And we find out on a follow-up MRI that he had a bladder tumor. So we did a transurethral biopsy, and we found that he have an invasive bladder carcinoma. So it was discussed at the tumor board. It was classified like a locally advanced unresectable disease. And the treatment plan was to treat him with enfortumab vedotin and pembrolizumab. Unfortunately, because of the lymph node, he had an obstruction to the ureter, so he had a nephrostomy on the right side. So first of all, you need to know like which are the guidelines to treat that kind of cancer. And for the first line systemic therapy for a locally advanced cancer, the preferred treatment was and is in 2026 enfortumab vedotin pembrolizumab. So you can always treat your patients with other immunotherapy, but that's the gold standard for the treatment of this disease. So I checked in the chart, and he did complete the pembrolizumab and EV cycle 3 on May 6th. And when I looked down on the chart, there was a screening done by a nurse in a private agency to give the pembrolizumab. And all the questions, all the answers was negative. And it's not because patients say everything's fine that it's all negative. So that patient was a Cree patient from up north, and he have severe problems like to understand well the questions. So you need to make sure that he's understanding well if you really want to have the right answer. And just before the cycle 4, he had blood tests with the medical oncologist, and we found a creatinine level at 634 for a baseline of 130 and a potassium at 6.0. So we sent him to the emergency department, and we found that he had a few weeks of nausea, vomiting, diarrhea, abdominal pain, and dysuria. So at that point, what are your differential diagnoses? Progression of disease. Thank you, Anna. UTI, good, good. So it could be nephritis too, okay, or obstruction of the nephrostomy tube. So if you don't know the answer, you can always check the immune-related adverse events nephritis guidelines in the NCCN. It's free. So when you have an elevated creatinine and you're suspecting nephritis, so these are the labs that you need to do. Those are the differential diagnosis that you can expect. For this patient, we did a scan of his abdomen, and we didn't find out any disease progression. Any new lymph node or Mets was negative, and the nephrostomy 2 was at the right place. So we can check that box for those differential diagnosis. So the answer is like he had a stage 3 oliguric AKI, multifactorial, likely driven by immune checkpoint inhibitors nephritis because of the white blood cell cast on the microscopy and the timing after the pembrolizumab. It was a good thing that we did a culture because we find out that he had Enterococcus fecalis, so we treated him with the right antibiotics. We changed the nephrostomy tube. We gave him IV fluids with BIC for the hyperkalemia, and we started him on prednisone at 2 milligrams per kilos. We did the monitoring of the input output just to make sure that everything going on the good side. And we did labs daily. And as you can see with the right treatment, we were able like to decrease the creatinine level like quite fast. And for the taper plan, that's the recommendation of the ASCO guidelines for the taper. So when you have a grade 4 or a grade 3, you need to improve your creatinine level till the grade 1, which is 1.5 to 2 times the baseline. So once you reach that point, you can start the taper. And the taper of the steroid dose needs to be at least on 4 weeks. You know the side effects of the steroids, but the patient don't, and the family don't too. So you need to explain to them what to expect. And it's not like very easy to understand because there's a lot of them. And let's say for short-term heartburn, bleeding ulcers, we are citing him on Pantoloc, but he needs to take Pantoloc 1 hour before the prednisone because like if they are taking all the medication at the same time because it's easier, it will reduce the absorption. You know that, the patient don't. So you need to explain everything with the education and you will have better results. Same thing for the hyperglycemia. We have a patient with diabetes. Maybe he didn't took like his glycemia very regularly, but now it's very important like to monitor those things. And sometimes a nurse is asking me why this patient is on antibiotics. And so you need to be on Septra 3 times per week to prevent pneumonia, Jirbéchi. So if you think your patient will be on steroid for more than 4 weeks, that's the case with a grade 3 or grade 4. So you need to start the Septra right away. So as a nurse, you need to make sure that the doctor or the nurse practitioner prescribe the right medication. Second case, Mr. H, 68 years old with active smoker, not taking any alcohol or drugs, had past medical history of hypertension, dyslipidemia, prostate hypertrophy, and GERD. He did a CT scan for dyspnea, and we find out mass in his kidney. So he had a surgery, left partial nephrectomy. We found at the PAT that he had renal cell carcinoma. So it was a stage 3. We did a CT scan after the surgery, and there was no residual disease or mets. So he met the medical oncologist, and the decision was made to start adjuvant pembrolizumab. So as per NCCN guidelines, when you have stage 3 renal cancer, you should have a radical or partial nephrectomy. And for a clear cell cancer, that's his case, adjuvant pembro or surveillance. And sometimes when you have cancer, you had a cancer, you want to do something just to make sure that you won't have a disease progression in the future. So, but that just wait and see could be a treatment too. And so it's very important for the patient to have an informed and clear consent, a free consent, because you don't know what you could expect with immunotherapy. So make sure as a nurse, like to that the patient is understanding well what's the side effects of the immunotherapy that he can expect, because I had a patient that developed myositis in this kind of situation, and he was not able to go back home. He was in rehab center, and after he died, the family said it was the worst decision of his life. So immunotherapy is not perfect, and a patient needs to know what's the side effects. So as you can see with Keynote 564 study, you can improve your overall survival with adjuvant pembrolizumab. The side effect could be the same as the sorafenib or sunitinib, but as I said, there's some side effect, and that could have a great impact on the quality of life. So for this patient, Mr. H, he was at the emergency with mild abdominal pain, mild nausea, jaundice, but he didn't have any chills or fever, and the review of system was negative. So that's his blood test results. So as you can see, he had a bilirubin at 6 times the upper normal limit. The ALT was 8 times higher. AST 14 times higher than the upper normal limit. So, question, what's your differential diagnosis? Hepatitis, good answer. Blood clot, bile duct obstruction, hepatitis, Hep C, good answers. So we did imaging first, CT abdo-pelvis had the emerge. So we found out with the yellow arrow that it was a gallstone maybe. So we asked for the MRI. And when you are asking for MRI, you need the consent, you need to talk to the fellow, you need to convince the coordinator that it's very urgent. So it takes a lot of time. And if there's other cause possible for this elevated liver profile. So you're not starting the steroids. And this patient, if he has an hepatitis, he needs steroids as soon as possible. So we did convince everyone to do the MRI, and we didn't find out any gallstones. There was no bile duct obstruction. There was no disease progression. So we started the methylprednisolone at that point. And on the ultrasound, there was no infection, no abscess. So we did a consult with the hepatologist. We ruled out the viral hepatitis, EBV, CMV mono, and so we were not waiting for those answers, but we started the methylprednisolone right away. And why 2 milligrams per kilo? So there's the ASCO guidelines and NCCN guidelines, and they are not saying the same thing. So NCCN is suggesting that you should give 0.5 to 1 milligram per kilo of methylprednisolone, and ASCO guidelines more like 1 to 2 milligrams per kilo. If you're asking an hepatologist, he will say like 1 milligram is enough because there was a study in 2020 that showed like more than one is not showing any greater benefits. And if you're asking a medical oncologist, he will say more is better. So because if you're not giving the more that you can at the beginning, you need to wait and increase the dose and wait again. So it could take time. And during that time, the patient is not feeling better. So we gave 2 milligrams per kilos. And as you can see, there was a great improvement after a few days. So we started the pre-taper and we sent the patient at home. But as in the end, a few months after, on the pre-taper, he developed a recurrence of the hepatitis. So it was a fail of the prednisone. So we start the second line with the collaboration of the hepatologist. So as a second line, we gave CellCept. It's an immunosuppressor. It's a prodrug, actually. The MMF, once filtered by the liver, is becoming the MPA, and the MPA is inhibiting the EMPDH. And by that, it's inhibiting the synthesis of the enzyme guanosine. And in the end, you're not creating B cells and T cells proliferation. So the side effects that you can expect are almost the same than steroids. So you need to tell the patient what he can expect with that too. So bottom line for this case, if you're a nurse, you need to inform your patients what to expect when they are starting this kind of treatment with no residual disease. For the last case, so it's important the power of knowledge, but it's important to share the power too. So Mr. D, 74 years old, with a non-small cell lung cancer, stage 2B, KRAS mutated, had a right lower lobe resection. He was started on carboplatin, pembro, and he was on maintenance dose pembrolizumab when he developed psoriasiform dermatitis. So the dermatologist started the topical corticosteroids. He received 20 sessions of phototherapy, and he started the risankizumab for one dose, one injection. He had past medical history of GERD, hypothyroidism, and melanoma, and he was on Synthroid, Pentalox, sucralfate, clobetasol, and folic acid. He was living his best life at home with his wife before he developed the severe dermatitis. Yeah. So he was in emerge for an increasing swelling of skin lesions, severe dermatitis on 90% of his body. He complained of itchiness, severe discomfort, low-grade fever, dysphagia, dyspepsia, weight loss, weakness, and gender, but he didn't have any rest symptoms. So as you can see in this study about immunotherapy with non-small cell lung cancer created by one of our presenters this morning. So you can have a lot of side effects with the immunotherapy for non-small cell lung cancer, pembrolizumab. And so for this patient, the most common one are for the patient with non-small cell lung cancer, the most common one are pneumonitis and dermatitis, or dermatologic aside immune react. immune-related adverse events. It can start like just after one treatment, but usually it's after a few weeks, and you can develop severe reaction like him. And you can develop like multi-system reaction, and you will see what's the case with that patient. So when I say like medical oncologists, more is better. So more and more and more can be better. So we started him on high dose steroid pulse therapy. So Solumedrol 1 gram every day for 3 days. We had an immediate profound anti-inflammatory effect. And the indication for severe psoriasis is it's indicated for his case. So he had a lot of side effects, not all of them, but you can expect the side effects that I present before with arrhythmias and shock. So it needs to be followed closely by the nursing team 24/7. The contraindication could be infections. As I said, he had low-grade fever, but this fever was created by the dermatitis, the infection of the skin. So if we are not treating the problem at its source, he will develop more infections. So it was okay like to start him on Solumedrol 1 gram. And we did consult dermatology. They said like to continue the Skyrizi. Skyrizi is an immunoglobulin monoclonal antibody. So it's inhibiting the interleukin who's responsible for the immune response. And we were expecting to reduce the burning sensation, the itchiness, the pain, and the redness. And you can expect side effects like upper respiratory infection symptom. That was not his case. Fatigue, a headache, itchiness, dysuria, eczema, rash. So side effect that he presented first with the dermatitis. So there's no perfect drugs. And we did continue the steroid cream. So if you remember, he had dysphagia, dyspepsia. So we did a consult with GI to do an EGD, and we find out esophagitis. So as you can see the results and the pictures. So the treatment for this is Solumedrol 1 milligram per kilo, but we already treated him with 1 gram. So he improved quite fast. So what I said at the beginning is like it's important to share the power of knowledge. So every week we have a multi-D meeting. So I share what's going on with that patient, and every professionals was really involved, like to help him to get better for sure, and to go back home living his best life with his wife. So everyone worked together, and we were able like to discharge him 1 week after with a good follow-up by his medical oncologist. So do you want to, we have resources if you want to double click like at home to see those tools. And if you have any questions, that's the break time, but we are here happy to see you after. Thank you.